a medicine and surgery degree alongside a master's in international health management and leadership from the University of Sheffield. Dr. Ifunanya is also a certified professional in healthcare quality, CPHQ, a certified ISO 915 lead auditor, and a certified Crucial Conversations trainer. Welcome, Dr. Iledibe.
Thank you so much for having me, and thank you for that very kind introduction, Dr. Baba. I'm going to quickly go ahead and share my screen. Okay, please confirm, everybody, that you can see my screen.
Yes, we can.
Awesome. Thank you so much. And thank you, everyone who's taken the time out on a busy Tuesday morning to join us to talk about a topic that is very important to me and to all of us here, which is patient safety. So obviously I'm wearing orange because, we go orange for World Patient Safety Day. And I want to kind of approach this topic a little differently from my wonderful speakers today. I'm going to be talking about the impact of poor diagnosis on patient safety. So my discourse today will follow this outline, and we're going to start today with a patient story. So, it's World Patient Safety Day, right? And at AHA Clinics, we every leadership meeting, well, what we call our leadership huddles, with a patient story. We do this for two reasons. One is that sometimes in the discussion about healthcare, the people that get forgotten are the patients. So we kind of do this to remind ourselves that patients are kind of our reason for being, la raison d'être, if you'd like to say it that way. And also to remind ourselves about what our true north is, which is patient safety at AHA Clinics. So this is a real patient story, even though the name is not real. So today, this is 8-year-old Busayo, who presents who presented to us a few years ago with abdominal pain, vomiting, and a 6-month history of abnormal gait. She had a prior history of neck stiffness and projectile vomiting, and also had a history of visual disturbances and impaired hearing. At the time, before presentation, this was 6 months ago, she was admitted at another facility, and then she was treated for malaria and typhoid, of course. Examinations revealed signs suggesting cerebellar ataxia. At that time, we requested an MRI, which revealed a large medulloblastoma with obstructive hydrocephalus. Finally, the patient was referred for surgery, and she had to have chemotherapy and radiotherapy. So I'm just going to show you a little of what her imaging was like. So if you look on the right side, you see what a normal ventricle is supposed to look like. On the extreme right, you'd see what a ventricle that had hydrocephalus. On the left, you see what Busayo's ventricles looked like at the time of presentation. And then the next image, you can see what looks like a white tennis ball right in the middle of the brain. That was the medulloblastoma that somebody did not ask for an MRI for based on her presenting illnesses and was treating for malaria and typhoid. So anybody who has ever treated a patient with cancer understands the benefit of time, how that affects the prognosis, how that affects the morbidity, and how that affects the mortality rates in cancer. And this is the very real situation we find ourselves. There are so many Busayos right now stuck in a loop in a healthcare system that keeps diagnosing them with conditions that they do not have and misses their actual diagnosis. So, what is a diagnostic error, right? It's a failure to establish an accurate and timely explanation of the patient's health problem. You can imagine that in Busayo's case, time was everything. And also communicating that explanation to the patient. A lot of the times as clinicians, we sit on our high horse. We have a diagnosis in our hands, hooray, but our patients do not understand. And because they do not understand, they cannot stick to our treatment, and they cannot expect, they don't know when the outcomes are bad, and they don't know when to come back if it's not what they expect. This diagnostic error also means when a diagnosis is delayed, is wrong, or is missed altogether. Now, complexity of preventing diagnostic errors is one of the top 10 safety concerns of 2024, as outlined by ECRI, which is the Emergency Care Research Institute, and it accounts for nearly 16% of preventable harm across healthcare systems. And most people will experience at least one diagnostic error in their lifetime. I mean, I think about that as a clinician. I have an 11-year-old daughter, and at about when she was 2, she started to have seizures. And I mean, I wasn't too worried about them. I had febrile seizures as a child, so I just thought, oh, she would grow out of them. But then she started to have seizures that weren't febrile, and then we had to do an MRI. And the MRI results showed a lesion in her brain that is only usually seen in people with dementia or children with severe cognitive impairments. But of course, I'm a clinician, so correlating clinically wasn't making any sense. So I asked for a second opinion, and I was told that those were just artifacts. But imagine the psychological distress I had to pass through to look at my perfect baby, first child, being told that she had this, these lesions in her brain, and then finally having that refuted. But I'm lucky I had the medical knowledge to know that I could go for a second opinion. How many patients don't have that? So I'll talk a little about the diagnostic process and what really goes into a diagnosis. So a patient experiences a health problem, right? They engage with the healthcare system. There's some information gathering. We get their biodata, then they see a doctor, they see a nurse, we collect vital signs, ask a few questions, and then they see the doctor to have their history taken, have a physical exam. And then based on the history and the physical exam, hopefully they have targeted diagnostic testing, either lab testing or radiology. And then hopefully we're able to put all of that together, synthesize, integrate, and interpret the information. And then we have a working diagnosis. And then we communicate this diagnosis to patients in a way they can understand. And of course, we ask for treatment. But the part that sometimes we forget is monitoring the outcomes. A lot of the times we do treat and street. So you have this, we found the diagnosis, eureka, and then we send the patient on their way. But we don't put in process a system to make sure that the patients are actually getting better. We don't do any follow-up, we have no follow-up visits, we're not calling back the patients to find out if they're getting better, and we're not learning. Because if we do that and we find out patients aren't getting better, perhaps we put the patient back into the diagnostic process, and then we shorten the time that they go through getting unnecessary treatments. And that's how a diagnostic process is supposed to work. So what are some of the benefits of taking the time and doing things right? Of course, you have improved patient outcomes. Patients are getting the right treatment. They're avoiding getting unnecessary treatment. And in cases like Busayo, right, they're getting early detection, things that could potentially not need, now become a life or death situation. Secondly, there's efficient resource allocation, targeted interventions for certain conditions. It's not like, sometimes we treat diagnostics like taking, a handful of darts and throwing it at the dartboard and hoping that one sticks. But we are already in a resource-poor environment, and every little naira counts to our patients. So cost-effective care is not just a nice to have, it is what patients depend on. So we have to do better so that patients don't end up spending money they don't have. Of course, enhanced quality of care. If patients get what they're paying for, then there's increased patient satisfaction. And we're able to improve the general trust in the healthcare system, right? And then also advances in medical research. We're able to understand diseases better, get more accurate results from clinical trials. I spoke to a group, a few years ago who were doing really interesting work. They were trying to develop a tool to help community health extension workers better diagnose fevers. This whole all fevers and malaria problem. And they were, this tool was accurately able to detect like 12 other conditions besides malaria. When they started to test this tool in the, community, they found out that 90% of the fevers were malaria, and which was curious because the data doesn't show that. And then they found out that part of the problem was that the malaria tests were poor. So even though the patients didn't have malaria, the tests were saying they had malaria anyway. And we all know that, data is garbage in, garbage out. If we put in bad information, it's going to give us bad results. So, diagnostic accuracy is important to get accurate clinical trials that can actually improve patient management. Now, to the crux of today's discussion, what are the impacts of poor diagnosis on patient safety? Of course, we've talked about delayed or incorrect treatments, like Busayo, who was having malaria and typhoid treatments when she really needed a neurosurgeon, increased morbidity and mortality, having wrong treatments, going from place to place, prolonging the course of the disease and causing more complications, psychological distress. Imagine the distress I went through when my child was misdiagnosed. And even though, I eventually got the right diagnosis, it was the longest month of my life. Loss of trust in the healthcare system. I mean, we all go through this, where patients want to Google everything that we do, where patients want to go abroad for even as little as a heniorrhaphy because they've lost trust in our healthcare system. Increased financial burden. Imagine having to go to multiple doctors before you can finally get a diagnosis, and how that impacts finances for our patients who mostly pay out of pocket. Of course, the legal implications when we're sued for incorrect diagnosis. So how can we improve diagnostic accuracy? It's not all doom and gloom. There's a light at the end of the tunnel, right? And we start by thinking about patient-centered care. I try to emphasize on communication because it's a lot of the times we sit on our high diagnostic horse. We give patients a diagnosis without kind of engaging them about what the course of the condition, what the treatments and the side effects of the treatments could possibly be, and what the outcomes are. For example, you get a mother who brings a child with a fever, and you do all your tests, malaria test is, mother thinks the child has malaria. I mean, everybody thinks everybody has malaria. And they come in, you do a malaria test, it's negative, and you think the child has a viral upper respiratory tract infection. It's very easy to just say, oh, your child doesn't have malaria, has a viral upper respiratory tract infection. Take this paracetamol and vitamin C, the child will be okay. That mother is most likely going to walk into the next chemist shop and get a malaria tablet because you don't know what you're doing. But just imagine this. You come to the same mother and then you say, we've done the malaria test. At this time, your child does not have malaria. I believe this is a viral upper respiratory tract infection. Now, most viral upper respiratory tract infections will clear in 5 to 7 days, but some might last up to 10 days. In that time, the child would have fevers. Some may be even as high as 40 degrees. I'm going to give you this paracetamol. The child needs to get it every 8 hours. If the fever comes back, shorter than 8 hours, you can give every 6 hours. However, in certain situations, these viral infections can become bacterially infected. In those cases, you may have an earache, you have a sore throat. If you notice any of these things, bring this child back. If this child becomes lethargic, if this child has any, of these other complications, is unable to eat, unable to swallow, bring this child back. That is that's a mother that if the child wakes up with a 40-degree temperature at 2 a.m., she's not surprised. She was told, she was informed. She's more likely to trust you. And you've told this mother, I want to see this child in 48 hours. She already knows that she has another appointment and she is empowered and she is supported to care for this child through the viral infection. That is a child that is a mother that's most likely going to trust you. And that's why patient-centered care is so important. Then when we talk about enhanced healthcare professional education and training, I speak to owners of facilities and, people who run facilities all the time, and all of us are going through this, right? Our clinicians are leaving, they are traveling, and we're spending so much on training. And it's like, oh, if I train this person today, they are going to leave. But you know what's even scarier? What if we don't train them and they stay and they see our patients and our patients end up with bad outcomes? So we need to train our healthcare professionals to better improve diagnostic accuracy for our patients, because we cannot be patients tomorrow. Then we have to standardize diagnostic protocols. This whole bring your mind idea to medicine, one of the hardest things I had at the beginning of trying to train doctors was, I come with my clinical acumen and a refusal to follow evidence-based guidelines, which are important for patient safety. Is something that we need to normalize in our facility. And then very importantly is a culture of safety. We need to teach our healthcare professionals a culture of accountability, which is when we make a mistake, we need to be able to say, I made a mistake, and you need to be able to create a culture that is a no-blame culture. At EHA clinics, our incident reporting is non-punitive. If a team member dispenses a penicillin to a patient who has a penicillin allergy and reports it as an incident, our culture says that we cannot, it's non-punitive, because we believe that we employ people who are reasonable and who have good intentions. And if it's a mistake, and the person is accountable enough to put in measures to make sure that that mistake does not happen again, then we use it as a teachable moment. And every healthcare facility, you need to have those conversations with your clinicians. Quality improvement initiatives, chart audits, looking at charts to make sure that diagnoses are accurate, chart reviews. Every week we do chart reviews with our doctors. We discuss cases, and in some cases we find out that the diagnosis the doctor has made is wrong. And one of the things we always ask at the end of our chart reviews is, if you had to see this patient again, what would you do differently? And so that the next patient can benefit from the wealth of that knowledge. Another thing we do is disease process audits. It might be impossible for you to look at every single disease process, but top 5 diseases, decide to audit them and use that to teach your doctors how to do better, teach your clinicians, and also monitoring diagnostic accuracy in things like even malaria. And today, we're going to talk a little about malaria diagnosis at EHA clinics and use that, just to have that conversation. Of course, improved communication and collaboration. Medicine is collaborative by nature. The doctors don't know everything. Every member of the team is able to have great input into a diagnosis. So giving a voice to your nursing team, to your pharmacy team, to your lab team, and also encouraging referral to specialists when, we've hit a diagnostic roadblock. Clinical decision support tools, very, very important. This is the next step. At EHA clinics in our EMR, we have, we offer BMJ best practices to give doctors the tools they need to make decisions on, including certain investigations they may not have thought of, or, certain treatment algorithms, in certain situations. In fact, you can even look at making symptom-based clinical decision support tools that lead people down decision trees and aid their decision-making, even when they choose their final diagnosis, right? You can choose a diagnosis of UTI, and then the clinical decision support tool says, but yeah, remember that this patient presented with vaginal discharge, which is not common in UTI, and gives you other suggestions, for you to be able to make an informed decision. And of course, advanced diagnostic techniques. And of course, I'm going to be leaving that to my awesome speakers today to talk about, because, using machine learning and artificial intelligence to improve diagnostics is, the future of medicine. So today, a brief case study about malaria misdiagnosis, which is probably the most commonly misdiagnosed condition in Nigeria. So what is the problem? So I looked at a few studies, and one done in community pharmacies and PPMVs showed that out of 457 febrile patients that sought malaria treatment and obtained an anti-malarial drug, only 3.9% tested positive to malaria, showed that over 90% of people were treated with malaria drugs they do not need. I try not to go into community pharmacies these days because sometimes it's hard not to get into the conversations. Sometimes it's hard not to bite your tongue when you have some of these discussions coming up. The other day I was standing in a community pharmacy, and a man walked in with his wife, and she had a list of drugs on her phone, and she was like, "Oh, I want Amatem soft gel and levofloxacin." And it took everything in me not to ask what is wrong with him. But that is the reality and what people do. Everybody prescribes over the phone. Once you hear fever, it has to be malaria. In the Niger Delta region, a study done there confirmed that only 54.74% of febrile cases in children were actually malaria. And then in Sokoto, 800 febrile children who were presumptively diagnosed with malaria who were examined, only 56% were confirmed to have malaria, while the remaining 44% were misdiagnosed to have malaria and treated for malaria, which they did not have. So what are the root causes? Now, there's a defined national algorithm to guide how fever cases and febrile conditions should be managed that is yet to be implemented. There's also a lack of a defined national and local quality control and quality assurance system to serve as check for practices at health facilities on approaches for managing febrile cases. Now, the defined operating standards and procedures to guide stepwise lab diagnosis, that talks about the reagents, the preparation of the reagents, the quality of the slides. These things are not followed. There's also a lack of sufficient diagnostic tools and equipment to make proper, specific, and precise diagnosis. Malaria PCR, which is very expensive and not readily available. And as basic as microscopes. I remember, one microscope we bought, the light was so poor, we had to return it to the manufacturers. And that's the reality of many facilities in Nigeria. For staff shortages leading to longer working hours, WHO recommends that for optimal malaria smear analysis, one scientist should not look at more than 40 slides in a shift. And some scientists are looking at upwards of 70 and 100 slides per shift. Of course, there's going to be some diagnostic apathy after that. Of course, sharp practices and lack of integrity. Sometimes it's just easier to say there's malaria than to actually try to look under the slides to actually accurately diagnose malaria. Sometimes it's just financials. You go to a lab, the lab is next to a pharmacy. It's easier for the lab scientists just to tell you that there's malaria so that you can go and buy medication from the PPMV. Of course, lack of skilled personnel had a lot of people leave from the brain drain. Training people for malaria diagnosis is expensive. And then, of course, there's this bias of endemicity. Endemic does not mean must have. A lot of the times when I have conversations with doctors, patients will present with vaginal discharge and fever, and then they'll just add a malaria test. And I ask why. It's like, oh, malaria is endemic. But there are other explanations for the patient's fever. It must not be malaria. So what are the solutions? Training, we've talked a lot about this. You can't spend enough on training, on testing proficiency, making sure that your training is actually working. Imagine going to university and getting all the information and you don't have exams. That's why proficiency testing is important. Process audits, actually sitting with your scientists, sitting with your doctors and making sure that they're diagnosing appropriately, they are going through the processes that they need to be going through. And after you do all of this in-house, external quality assurance programs, send your slides to other facilities of like minds who also have ISO certifications, who are also trying to do the right thing and check that you're doing the right thing. So we'll talk a little about our experience at EHA clinics. This is just over this year. So we give ourselves 90% is our benchmark for accurate diagnosis of malaria. This is for this year, we've done 100, 100, 100, and we dropped a little in July and August, as is expected, sometimes because we got in new staff and we see these drops whilst we continue our proficiency testing and training. But I'm going to give you an interesting insight. So, and when we have a new clinic, we let the clinic run for a while before we start kind of monitoring accuracy and putting in place our normal processes. So in May, I think, we noticed that in our Lagos clinic, usually we do a two-step malaria test. So we do an RDT, which is a high quality pan-RDT that checks for 4 types of malaria parasites. And then we follow up with a smear. So we noticed that, when there's a discrepancy between the RDT and smear, usually it's about 1%. But we noticed in our Lagos clinic was about 35%. So we actually started a QI project to kind of understand why that discrepancy was there. So we started the QI project with a root cause analysis. And it was so interesting when we had the conversation, when you say bias of endemicity, we saw it there. So one of the first conversations we had was like, oh, why do you think that there's so much discrepancy? And why do you think you're seeing more malaria parasites than, the data suggests? And the first thing I was told was, well, where we are, there are a lot of bushes. So we expect that the patients should have malaria. So the scientist was going into the slides expecting to see malaria. There was another funny story when we're going through the training process and retraining, and she had looked at a slide that was negative. Her trainer looked at a slide that was negative, and she didn't believe herself. And we're like, trainer was like, why? She's like, oh, but the patient came in vomiting. So even the bias of knowing the patient's condition affects the results and affects what the scientists were seeing. So we're still on it. As you can see, June or July, just a 1% change, but we're hoping that before the end of the year, we can get them to doing what the rest of the teams are doing. But overall, we're doing well. This is our external quality assurance with the MLSCN. The past result is 50. In 2023, we did about 74%. And as you can see, in 2024, we've done about 95%. So we're slow going, we're doing well. Of course, challenges that I mentioned, skill of new staff, bias of staff, and patients. You'd be surprised how many patients do not believe you when you tell them they don't have malaria, because everybody has always told them they have malaria. I've had conversations about, oh, when my malaria comes, it comes with sore throat. Or when my malaria comes, it comes with leg swelling. So one of the things that we're doing, we're trying to enhance our team's malaria diagnostic capabilities. We currently have 2 WHO trained microscopists that manage our malaria quality program at EHA clinics, and we're training a 3rd. We recently completed another refresher training on our staff on recognizing pseudoparasites. Of course, continuous training and retraining members for process improvement. We'd love to hear, see something, say something, make a mistake, say something, we'll train you. So in conclusion, consequences of poor diagnosis extend far beyond the immediate patient encounter and often leads to delayed treatment and preventable harm. Now, addressing these risks requires a collective effort to improve diagnostic accuracy through better training, enhanced communication, and the use of advanced diagnostic tools. By prioritizing patient safety and creating a culture of continuous improvement, we can ensure that patients receive the right care at the right time. Now, safeguarding patient safety is not just a clinical responsibility, but an ethical one. We have to do better for the boosters out there. Thank you very much. And thank you for having me, team. I'm going to stop sharing my screen now.
Thank you very much, Dr. Ifnaya. Thank you so much for that wonderful presentation. Do we have questions from our participants? We do not have questions. Do we have questions from those online? Okay, we do not have questions. Do we have questions from those on our YouTube channel?
None for now.
None for now. Okay. So in the absence of any, thank you very much for that beautiful presentation, Dr. Ifnaya. In the absence of any presentation, I'll just go ahead move on to introduce our next speaker. I will share my screen now. Okay, excuse me. Please confirm if you can see my screen.
It's coming up.
Okay, all right. So we'll be taking our next presentation from Miguel Alices, who is the Business Development Director at Idoven. Can you see my screen?
I think you need to try reloading.
Okay. Okay, sorry, I think I need to. So I will just go ahead to. I'll just go ahead to introduce the next guests while I try to navigate this. So, like I mentioned, our next presenter is Miguel Alices from Idoven, who is the Business Development Director at Idoven. Sorry, I'm trying to get my screen to come up so that I can share. Or Obina, please assist me with sharing it, if that's okay. Obina, can you hear me?
Yes, I'm coming out to that.
Okay. All right, thank you. So our next presenter is Miguel Alices, who is the Business Development Director at Idoven. Miguel is an expert in the medical devices sector and healthcare technology, with over 2 decades of experience driving innovation and improving patient safety outcomes through his work at renowned companies like Boston Scientific, Johnson & Johnson MedTech, and Essential. Currently, Miguel leads business development at Idoven, a cutting-edge health technology company pioneering the early detection and precision medicine for cardiovascular diseases through artificial intelligence, pushing the boundaries of what AI can achieve in healthcare. Miguel's extensive experience, deep commitment to innovation, and unwavering focus on patient safety makes him an ideal speaker for this event. He will share insights on how AI is revolutionizing cardiovascular care by mitigating ECG interpretation errors and enhancing patient safety, offering a glimpse into the future of healthcare. Welcome, Miguel.
Thank you, Dr. Baba. Thank you very much. And thank you to AHAC Clinics for inviting me here today to this interesting and very important topic. I'm going to try to share my screen. Please let me know if you can see it correctly. Can you see my screen?
I can see your screen.
Perfect. So thanks again for having me over. As commented on the introduction, my goal today is to give you a quick recap of what AI is doing today around ECG interpretation and how it can now and in the future actually help on patient safety and improving ECG interpretation. These are my disclosures. I think it was mentioned before. I'm an employee of Idoven, and Idoven is a Spanish company developing algorithms. Again, all the things that we're going to talk today are my opinions, so not related to always Idoven. So when I was thinking about this topic, I was thinking how to structure it. So the way I decided to structure it was in 4 different areas. The first one is why. Now, why do we need to talk about AI in ECG interpretation? Why is there a need out there to do so? The other one is why now? Why can we do AI ECG interpretation with AI now that we couldn't do before? The third topic will be around how can AI can help me in my clinical practice now and how it can help me in the future. And then another topic, because there's a lot of comments around it, which is how should doctors work with AI? How do doctors what do they need to do to incorporate this AI, in this case for ECG interpretation, on their clinical practice? So why do we need AI in ECG interpretation? So as you know, ECG is a non-invasive, very easy to use, cheap test that is the entry door for the diagnosis of every cardiac disease. We will argue later in the presentation that it can be used for detecting non-cardiac disease. This is the reason that more and more devices are actually building the capability of ECGs. It used to be there was only the 12-lead rest ECG, the 12-lead Holters. Now we have patches of 1 lead that you can stick in your chest for 1 week. We have implantable loop recorders. We have watches that can actually collect ECGs. We have weight scales that actually collect ECGs. So that is making a huge increase in the number of ECGs that are being performed. It's expected, and this comes from an external research, not from our estimates, that the number of ECGs this year will reach around 600 million in 2024. And this number is almost going to multiply by 3 to 1,700 million ECG by the year 2030. And you have to do something with all these ECGs. You need to interpret or analyze them. And this is already and will generate a huge burden to the healthcare systems and to the doctors. It's actually estimated that just in Europe, last year, there was around 1 million hours dedicated per day by healthcare professionals, that means nurses, doctors, and physiologists, in interpreting ECGs. An interpretation that is not easy. There's a Journal of American Medicine Association. There's an article in that magazine that did a meta-analysis of 78 clinical studies and came up with an average precision for non-cardiologists for all types of arrhythmias of around 54%. Of course, since the beginning, since the first devices that have been collecting ECGs, there's been algorithms that have been trying to help doctors, help healthcare professionals to better identify. Most of them that are currently being used are based on the Pan-Tompkins algorithm. This algorithm was created in 1985 and is basically trying to detect the peaks of the waves. And then based on that, it goes down and detects the next wave and detects the peak. It's called cycle length interval. This type of algorithms works fairly well for many of the arrhythmias, but if there's a lot of noise, if the quality of the ECG is not good enough, or if for certain arrhythmias, it has some room for improvement. It's been improved over the years with additional filterings, additional analysis, but I'm sure that many of you as end users of this algorithm can see that there's still room for additional algorithms that can improve and help on the diagnosis. And why now? Why are we all talking about AI now? No? So basically because we can. There's been exponential growth in computing type power, especially in the last 10 years, that has enabled us to do software and develop algorithms in a totally different way. To the graph for the left, for example, the graph that you can see in the bottom the years, and on the y-axis, you can see the flop. The flop is a measurement that tries to calculate how many basic arithmetic calculations can a computer do in 1 second. Arithmetic calculations as subtraction, addition, multiplying, and dividing. So if you can see, on 1950, there was a first algorithm that developed a robotic mouse that was able to go through a maze and remember its way back. It was a first algorithm. It used 40 flops. Since the 1950 until 2010, the capacity of the computer has been increasing to 1.4 times a year. And starting in the year 2010, it's been increasing by 4 times a year. Reaching numbers and capabilities, for example, in the year 2022, there was another algorithm called Minerva that was able to do any type of complex mathematical problems at college level that was using 2.7 billion petaflops. There's so many zeros in that number that I don't even know how to turn out to describe it without using the cheat sheet I have. And it's not only the computing power, is that we can now storage massive data sets with a lot of dimensions, and we can actually collect the data in a very different ways, which is critical to train AI. We are now having more efficient lines of code that helps us optimize the AI algorithms. So what this is enabling us is to program or to do software in a very different way. Traditionally, what we had is we had some data, we had some experts, and those experts, came up with some rules. So, it was like if condition, then action. And that gave the answer. So if red, stop the car. If you see RRR variability and there's no P wave in an ECG, then there's an AF. So that was the traditional way of programming. Now, with AI, with machine learning, we could do it in a different way. Now what we can do is get all the data, with all the dimensions that we need, and get the answers, and allow the machine learning, allow the algorithms to try to look for patterns, try to look for correlations among the data and about dimensions, and come up with rules. Let's see a very easy example. My favorite movies. So I like thriller movies. That's movies I like. So every time I'm in Netflix or I'm in front of the theater to go to the movie, I use the traditional algorithm. If thriller, then I like. If not thriller, then I will not like. But this doesn't work all the time. There's many thriller movies I do not like. And many times, with either my wife or my kids win the discussion, I end up watching other types of movie that I really like. So if I had a lot of money and a lot of time, one of the things we could do was develop an algorithm in which I would feed into the algorithm the different movies with all the dimensions, like the length, the country of origin, the actors, the director, if it's based on a true story, where it was filmed, every single dimension I can think of, and then tell the algorithm, this ones I like, and this ones I did not like. And what the algorithm can potentially do is start looking at correlations between those movies that I like and those movies that I don't like, and try to find new dimensions, new rules to help me identify how well I'm going to like that movie. Maybe I like movies that are based on true stories and they have a director that is Tom Hanks, and there's always a happy ending. There's some things that things that I've never actually thought, and there are patterns that are not easy for me to identify, and the AI can actually find it. So that's the new power of computing. And the beauty of this is they can do it really fast, and it can actually continue learning. So as I continue feeding new movies, new information, the algorithms can continue improving, and it can do it at a very, very fast pace. This is another example of an algorithm called AlphaGo Zero. I've never played the game of Go. It was supposed to be originated in China more than 4,000 years. You can see how it looks in the picture, and it's supposed to be the most complex board game, much more complex than chess. And in this case, they developed this algorithm that started in day zero with basically no prior knowledge of the game, and just some minor knowledge of what the rules were as an input. So the algorithm started learning and playing and learning and playing and learning and playing, And it was able to start surpassing, all the other software and even the humans. So in the amount of 40 days, it became, arguably the best player in the world. So this is what AI can do, So what can it do in ECG interpretation? And when I talked about this, and when I was thinking on the topic, I wanted to divide it in, that's three areas. One is what it can do today. So what is available, because several companies, including Eindhoven, are already offering. What's next, or what could potentially be next, because there's several groups that are actually working on it and, may be a reality in the future. And then what I call redefining traditional metrics. Not sure if I use the best title, but let me explain when we get there. So what are companies and groups doing today? So what we're basically doing is we're trying to collect all that information, all that knowledge for more than 100 years of cardiology and ECG analysis. And we're trying to collect as much information as we can from doctors to try to train new algorithms that can actually provide a precise, consistent, and standardized interpretation of the ECGs that do not get tired, that they don't lack experience, and that they have the right training instead of doctors that don't have the cardiologist training. And we're focusing right now on trying to detect patterns, arrhythmia patterns. So we have AF, we have AB blocks, we're talking about ventricular tachycardias, QT, ST, with the different types of devices that are right now in the market, being the 12-lead rest, being the halters of 1 lead, 2 lead, 3 leads, 4 leads, so different types of devices. So that's one area where many companies are currently working on, and they're starting to provide solutions out there in the market. Another area where many companies are working is on the patient monitoring. As you know, there's a lot of patients that are currently in the hospital or in the house with different devices, and they're sending data continuously. And this is creating a huge burden because that data needs to be reviewed. So many companies are trying to position themselves in between the devices and the doctors by providing an additional layer of validation, additional layer of calculation that can help actually detect those events that are real with those that are false positives, eliminate noise, try to look at small patterns to send alerts, in the goal to reduce the number of time, or the amount of time that doctors need to dedicate to review it, so that doctors can dedicate to those events that are clinically relevant. Some examples of this too. So this is probably one of the first clinical trials that show equivalence between an algorithm and cardiologists. This was published in the year 2019 in Nature, and it was an algorithm that was developed with 30,000 patients and 64,000 ECGs that was developed and was trained to identify 12 arrhythmias. The arrhythmias you can see: AV block, atrial fibrillation, supraventricular tachycardia. Then once it was developed, they took another 300, obviously different patients that had not been used in the training, another 328 patients with 336 results, and they compared against expert cardiologists. The results you can see it in the confusion matrix, where you can see the results from the cardiologist and the result of the algorithm, matching accuracies in level with those of the cardiologists. This was one of the first ones. Since then, there's been other companies, including ourselves, that are working on expanding the number of arrhythmias and expanding the number of devices. In this concrete case, it was a single lead, one lead device. So many of the other companies are working on expanding it to 12 lead, 22, to halters, and different devices available in the market. Another example, and this case is a clinical study done by us, is what we were talking about on patient monitoring. So one of the devices that you can use for patient monitoring is the implantable loop recorders. The implantable loop recorders are devices that you put under the skin, and they do a continuous cardiac monitoring for a period of 2 to 3 years. And they continuously send, the events to the hospitals. One of the challenges that there is that there's a lot of false positives. The patient puts the phone in his chest, in his coat. That creates a lot of noise. The device sends an alert. So there's a lot of information that is being produced, and that generates a huge burden to the hospitals. So what we try to do in this case is what we commented before, putting an AI between the device and the doctors. So in this clinical study, what we took was 2,500 events transmitted from different patients, and we run it through two different independent cardiologists, and we run it through Willem. What we were able to see is that from those 2,500 events, almost 1,100 were false positives. And by using AI, we would have been able to reduce it to 22 false positives, a 98% reduction. And as you can see, across the 4 types of arrhythmia that the device was able to identify, AF, VT, bradycardias, and asystole, providing, enabling the doctor to free a lot of more time not having to review those false events. Another thing that we've been doing with patient monitoring is understanding if we can expand the current capabilities of the hardwares that have been used. So in this case, what we try to understand is, okay, we have a hardware that is currently good to detect 4 arrhythmias. Can we actually, with AI, expand the number of arrhythmias that it can find and give a more comprehensive understanding to the doctors? So we took 7,800 events from 25 from different patients, and what we did was try to understand how many arrhythmias we could detect with precision. And we were able, with the use of AI, to go from 4 that was currently detected and transmitted by the device to 25 different types of arrhythmias, giving an average and a pondered global accuracy of 88%, and giving the doctors a much more comprehensive understanding of the type of arrhythmias that patient was suffering. At the same time, because of the reduction of false positives, we were able to reduce those interpretation times from 11 minutes to 6 seconds. So these are some examples of what AI is providing today and what different companies are actually offering out in the market. What's next? Where are some companies working, some investigational groups working? And I'm sure I missed some of them, but this is, some of the ones that I consider are more interesting. So one of the things that us and other companies are working on is to try to detect those small changes in the ECG, those changes in the ECG that are very difficult to see for a human eye, and that can help detect patients with undiagnosed diseases, or it can help us understand how a disease is going to progress. There's many different groups and many different companies working in atrial fibrillation, heart failure, low ejection fraction, heart failure decompensation, amyloidosis, and other conditions that impact the heart. Another area where other groups are working in is in non-cardiologic diseases with the ECG. As you all know, I'm not a doctor, so as you all know, many of the diseases that you have outside of the heart can impact the heart functionality. And if they impact the heart functionality, then there's changes in the ECG. So what groups are trying to do is, can we actually see those changes? Can we actually put a pattern on those changes and try to use the ECG, which is a very easy to use, a non-invasive and cheap test, to try to diagnose diseases that are outside of the heart? So that's one of the areas where some companies are working. Some examples. This is again from Eindhoven. As you know, atrial fibrillation is a disease that moves from paroxysmal events that are short events that stop by themselves And then there's an atrial remodeling, the atria enlarges, and then the patient slowly moves into persistent AF, where the AF is all the time and it's not possible to stop it. And that's where the patients start having more issues on the quality of life as well as life expectancy. So in this clinical trial that we did with patients with pacemakers or ICDs, implantable cardiac defibrillators that had a lead on the atrium, it was around 4,600. What we did was try to detect small changes in the atria that the algorithm was able to start detecting that could actually indicate if there was a start of the electrical remodeling. And once the electrical remodeling started, then you know that the physical remodeling was going to follow and the patient was going to move into persistent AF. So we were able to start detecting points, try to understand how fast that remodeling was going to be, and try to do an estimation and a prediction of how fast that patient was going to move into persistent AF. And we were able to detect and predict persistent AF with 6 months in advance. Again, the goal, this is only on R&D, but the goal is that maybe in the future, we can do the same even with external, devices, and that can give you doctors new information to take decisions. Because depending on that slope, so if you have an older patient that has a horizontal slope that's going to progress very slowly into persistent AF, maybe you want to do a more conservative treatment. But if you have a younger patient that has a more steep slope and is going to move faster in persistent AF, then maybe you want to do a more aggressive treatment. Some other examples around, for example, amyloidosis. Amyloidosis, as you know, is a life-threatening disease that is very difficult to diagnose. I mean, the early signs of diagnosis of the disease are, fatigue, are weakness, shortness of breath. They talk about numbness, pain in the hands and in the foot. So many times they're misinterpreted for other diseases, and the average time of diagnosis is around 2 years, and it needs a very specific blood or urine test. So the Mayo Clinic working, took 2,500 patients in a retrospective study, getting all the data from the year 2000 to the year 2019, and use 60% of that data to train a model, only using the ECG, to try to understand if the ECG by itself could actually give you some kind of detection. Then, once the model was detected, they used 20% of that data to run the model. And with that 20%, the model that they developed was successfully predicted the presence of cardiac amyloidosis 6 months before the effective clinical diagnosis was performed for 59% of the patients. So imagine the opportunity of using this 12-lead rest to detect dangerous diseases like this one. And this is also true for non-cardiac diseases. As you well know, the heart, works, the electricity of the heart works based on the ions of sodium and potassium. So if you have problems in the kidneys, if you have problems in the livers, and there's an imbalance of those sodium and potassium levels, then, there's changes in the way that the heart contracts. And actually, there's been studies that see that, problems in the kidneys, for example, are related to changes in the T wave, QRS, and ST segments. So there's groups that are trying to detect, trying to provide, an algorithms so they can actually able to detect those changes early enough so you can use an ECG to detect those type of problems. Same with hyperthyroidism, that right now requires a blood test, that requires certain infrastructure, certain reagents, biochemical reagents to perform the test. There's groups that are working on how to detect from an ECG the hyperthyroidism. So this is, what many groups are working in. And then what I call redefining traditional metrics. And again, not sure if I chose the right title, but what I'm trying to say is, so, the interpretation of ECG has been there for a long time. As well known, is well based on established parameters. We all know that the P wave is 120, QRS 100 milliseconds, the millivolts, what's the shape of the ST, and it's based on population-based that, englobe every one of us. This is to simplify it for everybody, for all the people that are trying to understand ECGs. They need to have simple rules to do it. But maybe with AI, now that we can see many other things, can we really think about readjusting these ranges to more patient-specific? Can we start thinking about how this changes based on age, or gender, or race, or medical history? Maybe depending on my medical history, my ECG should be considered normal by the machine, and don't give me and don't scare me every time I go and do a test. And not only that, because there's many diseases that we currently identify where we do a treatment and then there's no response. The patient does not respond correctly to the treatment. One example, for example, being cardiac resynchronization. So we know that there's a long QRS, if there's a low ejection fraction, we can actually put them in on other parameters, of course. We can put them into the OR room, put them at cardiac resynchronization therapy, which is an expensive procedure, it's an expensive device, and then 30 to 40% of those patients do not respond to the treatment. What are we missing? What can we actually change in how we see the ECG, if any, that can help us identify those patients that are really gonna improve from that treatment? And that's, for example, one of the things that other groups, including ourselves, are doing. In our case, we're actually working on acute myocardial infarction and ST elevation. As you all know, ST elevation is one of the indicators of myocardial infarction. But then 10 to 20% of the patients that actually have an ST elevation do not go to the cath lab and do not have an occluded artery. And there's many patients that have an occluded artery and do not have an ST elevation. So what we're doing with this clinical study, which is in Europe and Latin America, what we're trying to do is collect data from the ambulances, collect data from the emergency services, collect those ECGs, and then compare it to the results of the cath lab and understand if there was occlusion or not. To try to understand if we can actually train an algorithm and show an algorithm that can detect things in the areas in the ECG that right now we're not aware, that can actually improve the way we detect and diagnose those type of patients. And how should doctors work with AI? Because there's a lot of discussion right now. There's a lot of, we were talking before the meeting, there's a lot of science fiction movies right now. So there's a lot of concern maybe sometimes around AI. And AI is just another tool. It's just another tool. For clinical practice, for clinical medicine to evolve, there's always been a new tool that has enabled us to look at the same data in a different way. This is exactly what we happen with MRIs, with genetics, with X-rays, with echocardiographs. We were just looking at the same with additional new technologies that enable us to see in different ways and measure in a different way. And that's just what AI is. AI is just another tool to try to help you on your daily decisions. And actually, all of the companies that we're working out there, we're trying to do the integration as seamless as possible. There's different strategies and different companies positioned, but most of them are basically trying to get the data directly from the hospital network, before you analyze it, or partner directly, or even their own hardware manufacturers are actually developing their own AI, or partner directly with the manufacturers, get the data, run it through the AI, and provide an analysis. That analysis is provided to the doctor that, together with analysis and diagnosis from other sources, as well as the physical examination and his knowledge of the patient, can actually provide the best diagnosis and treatment possible. That's what AI is trying to do in ECG interpretation, just provide you another tool so you can provide better decisions. So as takeaways, and we just mentioned this, I mean, for innovation to happen, you know, there's always been new technologies that has allowed us to measure things in the ways that have not been measured before. And that's what AI is. AI is simply measuring the ECG in new ways and potentially helping to simplify the diagnosis so you can spend more time on the patients and less looking at the ECG signal. And potentially, because many of those clinical trials that we discuss may never work, you know, opening new opportunities for early identification and risk stratification of patients. AI is just a tool. AI will not replace doctors, but doctors that use AI will replace those who don't. So I'm going to stop presenting now. Not sure if there's any questions.
Thank you
Comments?
very much,
Comments as
Miguel,
well?
for that wonderful presentation. Thank you so much. I believe our participants enjoyed themselves, as I did. We have one question here from Ephraim Timothy. Hi, my question is there a specific AI program created specifically for the interpretation of ECG? And how can one use the AI to interpret ECG results? Thank you.
So I don't know if I fully understand the question. Is there specific programs that can actually use for AI interpretation?
Yes.
And what are the outcomes at this point? So the answer is yes. There's different programs that us and Eindhoven are currently having some commercially available programs as well. There's other companies in Europe, in the US and Asia that are currently actually marketing different type of AIs. And basically, in our position, for example, we can currently detect 22 arrhythmias for 12 lead rest, Holters of 1 to 3 lead, and implantable loop recorders. And what we actually provide is a report based on the AI that can actually right now only interpret and detect some of the basic arrhythmias that we commented before as AV blocks, BTs, AFs. But we're still working, as you see, on those prediction capabilities and early diagnosis of other diseases. Not sure if I was able to answer the question.
Yeah, I'm sure you answered this question. Thank you very much. Any more questions from any of our participants before we proceed? Any questions from our YouTube channel? Obina?
None.
Okay, all right. Okay, thank you very much. I will proceed to introduce our next, in the absence of any question, I will proceed to introduce our next presenter, Dr. Afolabi Ube, who is the Chief Medical Officer, SimLab. Please let me know if you can see my screen. Okay. Obina, will you be kind enough to help me share your screen? Hello, Obina. Okay. All right. Thank you. So Dr. Afolabi Ube is the Chief Medical Officer for SimLab Diagnostics. Dr. Afolabi Ube is an alumnus of Ladocare Akintola University of Technology, Ogbomoso, and an award-winning fellow of the National Postgraduate of Medical College in Nigeria. He is a consultant pathologist with SimLab Nigeria, and he coordinated the COVID-19 project of SimLab Nigeria during the pandemic. Dr. Afolabi is a result-oriented pathologist with expertise in management of medical diagnostic laboratory, infection prevention and control, management of infectious disease outbreaks, and biological risk assessments. He is motivated by providing quality pathologic services to improve the health outcomes of Nigerians. This is the force behind his love for SynLab Nigeria. He is a facilitator and loves sharing knowledge about quality health practices. Dr. Obey is an executive of the College of Nigeria Pathologists, CNP, a member of the Society of Quality Healthcare in Nigeria, a member of Infection Prevention Control African Network, ICANN, member of Clinical Microbiologists and Infectious Diseases Society of Nigeria, CLIMITSN, member of European Society of Clinical Microbiologists and Infectious Diseases, ESCMID, Biological Safety Association of Nigeria, BSAN, and others. He is the Chief Medical Officer of SynLab Nigeria with the responsibility of leading the medical strategy, supporting and coordinating a sustainable, responsive diagnostic network with the aim of achieving the company's mission. He is a loving husband and father, lover of fun, and a believer in a new Nigeria. Welcome, Dr. Afolabi.
Thank you so very much for the generous introduction. Without wasting our time, I would go straight to my presentation. This afternoon, within the limit of time, we're going to be talking about the role of laboratory testing in accurate diagnosis. And I usually want to start with a clinical case scenario, and it appears to me as if the first presenter, had a spy into my slide. But that notwithstanding, this is important so that we can understand, the context of the conversation. A 6-day-old neonates. Neonates are children babies that are born within the first 30 days of life. Presented to a facility with yellowness of the eye, lethargy, and refusal of feeds at about 10 p.m. And so the doctor that saw reviewed and gave a presumptive diagnosis of neonatal hyperbilirubinemia, meaning that, based on these complaints, the doctor felt that, the bilirubin is high, meaning that the baby, is jaundiced. And then so the patient was placed on phototherapy machine with the intention of reducing the concentration of the bilirubin. And again, the doctor needs to take a decision whether this baby needs to do exchange, what we refer to as exchange blood transfusion in neonatal practice. So the sample was sent for investigations to help to take a decision as soon as possible. Results were available within 6 hours, and the results were not within the threshold to initiate exchange blood transfusion. So the doctor felt, okay, what we're doing is still on course, and let's intensify, and then we'll review again. 18 hours post-admission, the patient, that is the newborn now, began to have high-pitched cries. And so clinicians in the house, high-pitched cry indicates only one thing, that this bilirubin has gone so high that it's beginning to affect the brain of the baby. And at this point, the damage becomes, irreversible. It becomes irredeemable. And then it becomes a permanent damage, to the growing brain. So a repeat bilirubin test, was ordered, and it revealed highly elevated bilirubin parameters necessitating exchange blood transfusion. Now, the question will be that what are the issues here? This is a true life scenario. Number one, for an emergency case like this, there is a delay in turnaround time. 6 hours is a long time to take a decision to have exchange blood transfusion because of the peculiarity of this case. Number two, the initial result was wrong, and so leading to clinicians taking inappropriate intervention. The baby ought to have done exchange blood transfusion. Perhaps the result is expected to come out within the first 2 hours, at the most 3 hours, and the baby should have exchange blood transfusion. However, the result stated otherwise, and so there is a delay. Now, if you look at the scenario, a test that is meant to be conducted wants to take a decision, they have to conduct the test 3 times. So there is increased cost of testing. And there is also increased hospital stay. There is increased healthcare costs. There is loss of manpower. And again, there is increased mortality. And what we usually don't talk about in our environment, in this scenario, the mother will go with the baby that has a permanent, irreversible damage to the brain. It becomes a long-term psychological effect on the immediate family and, of course, extended families and loved ones. Right. So this, for me, is a summary of when the laboratory is not doing what is expected to do. And of course, it affects ultimately the patient's safety. So to the presentation, why accurate diagnostics matter? Why does it matter? Diagnostic error has been found to account for 10 to 15% of adverse events in healthcare globally. This refers to where things are done correctly, everything is in place. Even at that, diagnostic errors still account for 10 to 15% of bad outcomes. And in Nigeria, we depend largely, about 60% of healthcare decision depends on laboratory results. And this is because by the time the patient is presenting in most of the facilities, the clinical course is not straight anymore. Every disease, even though diseases don't read textbooks, but there is a clinical pattern you will expect from every disease. But because of where the patient has been to, initially to the pharmacy, even before I get to the pharmacy, to the brothers, sisters, aunties, or nephew, who supposedly has had a similar illness 2, 3, 4 weeks ago, prescribed initial medication, and then from there to the pharmacy, from there to another hospitals where you may not even have a doctor or a trained nurse. And so by the time it's coming to the real healthcare setting, the disease pattern has been modified. And so the clinician needs laboratory, depends largely on the laboratory results to help unravel the complexity in this clinical scenario. And unfortunately, again, the laboratory, if perhaps now becomes unhelpful, it increases, the burden. So 40% of misdiagnosis result from inaccurate laboratory results. And this is huge, actually. Accurate lab testing ensures correct diagnosis, appropriate treatment, monitoring of disease progression, and ultimately, patient's safety. So what is the role of laboratory testing in healthcare? Testing is the foundation of medical decision. I have stated in the previous slide the volume of healthcare decision that the depends on laboratory testing globally, between 60 and 70%. And therefore, it is important that the laboratories are operating at a maximum capacity to ensure, patient safety. So the role includes diagnosis, helping to identify the presence of disease, the presence of infection. It also helps in monitoring of disease progression. A patient has been diagnosed with a particular ailment clinically and supporting with laboratory diagnosis. There's a need to monitor progression. Sometimes, especially in public health and preventive medicine, screening, laboratory also helps to screen, especially for chronic diseases like diabetes and several others. The laboratory also helps in personalized health care. What you expect at those points is that individual, now has a personalized treatment plan based on the genetic makeup of individual. The laboratory also helps in risk assessment. It also helps in research and development, because all the medications, treatment algorithms, and everything, will have to go through research before it's been developed and before it's been incorporated, as a modality of care. And these are the various roles the laboratory plays in healthcare system. And so it is important that we have reliable, results that clinicians work with, and then this is actually the role. And so what is the importance of precision in lab medicine or in laboratory testing? Now, we've been able to establish, number one, it's the critical role that the laboratory plays in healthcare. And then it is one thing to conduct the test. It's another thing to ensure that the results are reliable, that the results are dependable, that the results are what clinicians will work with, or what is going to ensure that the patient is safe. Right. So precision results reduce misdiagnosis rates, which can reach 30% in some rural areas. And over 70% of patient treatment for conditions like febrile illness rely on diagnostic tests. This has been established. So inaccurate laboratory results, for example, may lead to antibiotics abuse, which is a major problem that we're facing currently in Nigeria. And this largely contributes to antibiotic resistance in our country. Right, you send a patient for urine culture, and there is no need for antibiotics. Lo and behold, the result is saying, oh, we can see Escherichia coli, and Escherichia coli is susceptible to this, and this. And of course, the patient, maybe because of the money he has spent, because of the trust he has in his doctor, because of the trust he has in the laboratory, commence the use of the antibiotics. Meanwhile, the antibiotics is not necessary at that particular time. This is a major cause, it's a major cause of resistance. And again, even when the laboratory is fine and the results are okay, timeliness, it's of essence. So timely diagnosis is crucial for patient safety, because it allows for early intervention and treatment. So delay in receiving test results has been found to contribute to 45% of preventable death in critical care. Like the case scenario, even though it doesn't lead to death, but then it leads to a permanent damage because of delay. So timeliness is also of essence. Nigeria of today, we face an average of 4 to 5 days turnaround time for non-urgent tests, and some urgent tests is still within 4 to 6 hours. Meanwhile, the results are meant to come out within the first 1 or 2 hours. These are issues that it's important that it be addressed. A case in focus is the COVID-19 testing, which of course I'm aware that most of us understand. Now you realize at those points, the turnaround time, most times, by the time we're within the first phase, the second phase, the turnaround time for most testings have been reduced to 6 to 8 hours. So it becomes easy for people with the disease to be picked because the duration of quarantine is less. And so the person is able to still hold on, expecting results within 6 to 8 hours. And the results will determine whether the person is free, it needs to be quarantined, or the person needs to be treated at that point. However, if results are coming out 2 to 3 days after, you realize that the rate of disease transmission, at this point would have increased significantly. So what are the factors that affect accuracy of laboratory results? These factors generally are divided into 3. These factors include pre-analytical, things that happens before the sample gets to the lab, to the point of analysis. Analytical, the things that are done, while the sample is in the laboratory. Post-analytical, events that happened when the test has been done and the result is available. It's been documented globally that 70% of diagnostic error are due to things that happened before the sample gets to the lab. And the Nigerian Medical Journal also reports in one of their published articles that 55% of diagnostic error, are pre-analytical, which I want to believe that it may actually be more than this, but of course, this is the report that we have. And the pre-analytical issues include sample collection, patient selection, timing of collection, appropriate sample bottles, appropriate sample handling, logistic and transportation, and several other things. For example, a patient is having vaginal discharge. It just came to my mind. And the clinician is thinking that, this most likely may be gonorrhea. And the sample of choice at this point ought to be endocervical swab, but then high vaginal swab is collected. Now, this, of course, is a major, because at the end of the day, the laboratory will analyze and give results. And then the result gets to the doctor. The doctor sees that what I'm expecting, it's not what I am having. And of course, misdiagnosis, mistreatment, ultimately, the patient starts to have trust issues with the clinicians. So it is important that right sample is collected at the right time, collected in the right way, collected from the right patients, samples are labeled appropriately, samples are stored appropriately, and samples are transported appropriately within the appropriate temperature, to the laboratory. Some samples are meant to be in ice pack, but we see samples, just drop them in containers and they transverse 25, 45 kilometers, in very hot temperature. They may not get to the lab in another 24, 48 hours. you are going to be having a lot of issues, with that kind of result. So these are major, and it's important because the pre-analytical issues boils down on things that happens before the sample gets to the laboratory. So it's important that clinicians and patients, general population understands the importance and the role that everybody needs to play in ensuring that the pre-analytical issues are well sorted. And of course, if we're able to do this, we would have reduced significantly, laboratory errors. Number two, analytical. Analytical speaks to instrumentation. What type of instrument are you using? Is your instrument correct or not? If the instrument is correct, do you calibrate the instrument? If you calibrate the instrument, do you maintain the instrument? Does the instrument go through periodic preventative maintenance? Now, what is the sensitivity and the sensitivity of the equipment to the analytes you are interested in? All these things are important when we speak to, instrumentation in the laboratory. Not just, oh, this equipment is fine, we're just going to buy the equipment and dump it there, and we start to use it. We are going to have a lot of wrong results in doing this. Reagents and materials. It is important that quality reagents are used, not just any available reagent. Is that reagent compatible with the equipment? Does the manufacturer say that, oh, you can use this reagent on this instrument, and your reagents, are they expired? All these are very important. And again, operator skill sets. This speaks to training. Initial training to understand the equipment the scientist is going to be using. Periodic training, to ensure that the operator still understands, the use of the equipment. Then from there, we move to post-analytical. That speaks to data implementation, error detection, and quality assurance, and both external and internal. All these are important. All these are factors. If they are not well considered, they are factors, that affects, the reliability of laboratory results. And again, the system factors. This speaks to the system that is operational within the laboratory space. Protocols, procedures. Some laboratories don't have SOPs. Even if there are SOPs, the SOPs are outdated. They are outdated. Even when the SOPs are available, they are not outdated. The SOPs are not even available for the end users to use. Some SOPs are meant to be pictorial, where you can see very close to the equipment. All these things, if they are not available, they affect, the accuracy of laboratory reports. And quite a number of our laboratories too were not accredited, either local accreditation or international seal of certifications. Most of our laboratories don't have this, and all of this ultimately would affect the accuracy of our laboratory results. So it is important that all these factors are meant to be addressed via rigorous protocol, continuous training, regular equipment maintenance, and ultimately, this will lead to quality results, and thereby ensuring patient safety. So how do we ensure accuracy in our laboratory testing? Number one, this talks about the best practice, to ensure reliable results. Number one that I want to speak to is standardized procedures. it is important that we have standardized procedures. A need for SOPs, like I have said, for all testing, including sample collection. There is a need for documentation of all procedures, right? So that when you deviate, it's easy to know that there is deviation, and it's easy to retrace the step backward. So standard operating procedures, documentation of all procedures, all of these will ensure consistency and traceability. Now, quality control, both internal quality control and external quality control, to ensure accuracy in laboratory testing, a laboratory, that receives samples for patient care should ensure regular use of control samples with known values to verify whether the equipment you are using and the methodology you are using is performing accurately. And this is one major area that most of our laboratories are lacking. It is important, I want to say that again, that laboratories use control samples, to ensure, to validate that the equipment and the method they're using per time, are performing accurately. And it's also important the laboratory participates in, proficiency testing. This will also ensure that the results that you're releasing to clinicians or the results you're releasing to the general populace, it's actually the result that is expected. Right, equipment maintenance. It is also important that our equipment are calibrated according to manufacturer specifications. And we also ensure that regular preventative measures are carried out on our equipment. These will guide against breakdowns, and it will also guide against inaccurate results. So not just that we're able to buy the equipment, you dump the equipment there. Like I used to say, buy any machine, get a sample, put the sample in the machine will generate results. Whether the result is resulting or not, it's a different ballgame. But to ensure patient safety, the result that the equipment generates should be, the result, as it were, should represent the true nature of the disease condition of the patient. And this will help the clinicians to take appropriate decision. And ultimately, it ensures patient safety. Right. Number 4, reagents management. It is important that you use high-quality reagents. It's not everybody that comes to the lab to advertise the reagents that the laboratory will buy, especially when it is quite cheap. That could cause problem. Laboratories should not use expired reagents. Right, some will say, oh, it's the shelf life. It will cause problem. It is also important that reagents are stored appropriately. Some reagents are meant to be stored in the fridge. Some are meant to be stored in the freezer. Some are meant to be stored at ultra low temperature. Some reagents are meant that when you open it, within 72 hours of opening the reagent, you must exhaust it. If you're not exhausting that reagent, you are not permitted to use it to run sample again. And the question is, imagine you open a vial of a reagent whose onboarding time is, say, 7 days. And the test is supposed to run, the reagent is supposed to run 100 tests. And within that week, you only had 50 tests. I mean, you'll be tempted that day 8, you want to continue to use it. Right, but then this is not what is expected from a laboratory who wants to guarantee patient safety. And that is why, for us as a country and for us as a people, there is a need to do a major overhauling of our system to ensure that these little things that people start to benchmark patient safety and cost, patient safety and wastage will be addressed by the modality, of laboratories that will run. Staff training. This speaks to initial training, and it also speaks to, periodic training. And the sample management, it's important that you have standard operating procedures for sample management, sample collection, sample transportation, sample storage, and all the rest. Environmental controls, the laboratory, it's supposed to understand the environmental requirements for all the equipment. Some equipment will start to malfunction at a particular temperature. So the AC within that space where the equipment is should ensure that the environment, it's okay for that machine to continue to function very well. And again, accreditation and compliance. Not so many laboratories in this country has ISO certification, and that's quite worrisome. Even our internal certifications, not quite a lot. These are issues. It may go beyond us here, but then for me, it's fine that we're organizing this. We're having a conversation about it. And of course, we'll take the conversation further and further until we begin as a people to make policies, and ultimately we'll start to make a shift from where we are currently to where, gradually towards where we think we should be as a people. And apart from accreditation, it is also important, that we comply to policies and procedures. So if a laboratory implements all these integrated strategies, not just 1, 2, 3, or 4 of them, all of them together, now it enhances the accuracy and the reliability of the laboratory testing, and ultimately it ensures our patient safety. And before I round up, let me quickly talk on the role of technology on improving lab accuracy. Innovation in diagnostics technology, like part provider and automation, we should move from the manual system to the automation system. And it has been found that automation reduces laboratory error for up to 80% of time. AIs and machine learning assist in interpreting complex data like imaging and test results. We could also start to invest or deploy point of care testing that are calibrated and validated, to ensure accessibility to healthcare. And of course, again, we could also move to the era of telemedicine, where all of the things may not be available at a particular location, but then you could link up with some other laboratories that had, all this support. Ultimately, it helps us to achieve a desired aim. And because of our time, yes, we have said this before, incorrect lab results can lead to inappropriate treatment, causing up to 30% of patient death in Nigeria. Accurate diagnosis can reduce hospital stay duration by 40%. It minimizes exposure to hospital-acquired infection. And in conclusion, I want to conclude by saying there is a need to invest in modern laboratories. And what I mean by modern laboratories, a laboratory that has the network of the things I had mentioned, standardization, quality control, reagents management, environmental management, equipment management, staff training, sample management, data management, and all the things that I've mentioned. It's also, and of course, continuous training of laboratory staff, accreditations, and AI-driven diagnosis, which will improve patient safety and reduce errors. Accurate, reliable laboratory testing is the cornerstone of safe healthcare and positive patient outcome in Nigeria. Therefore, healthcare professionals, healthcare policy makers must work together to strengthen diagnostic system to ensure patient safety. Thank you.
Thank you very much, Dr. Afolabi. Thank you for the very beautiful presentation. We do not have any questions at this time. We will take the rest, if there are any, we'll take them at the end of the general presentation. Thank you very much again, Dr. Afolabi. I will move on to introduce our next guests. Okay. Obinna. Hello, Obinna. Okay. Thank you. So our next guest is Dr. George Udoku, who is the General Manager for GE West Africa. Dr. George is a medical doctor and business leader in medical devices with extensive experience in strategy, new market entry, project development, and sales management. He is currently the General Manager, GE Healthcare West Africa. In his role, he is responsible for driving a coherent commercial strategy across the GE Healthcare businesses in West Africa and optimizing the use of commercial service resources in achieving GE's goals to help deliver sustainable and accessible integrated patient care across the region. Prior to joining GE, he was with Philips Healthcare, where he held several leadership roles in both market and business organizations over a 10-year period. He was responsible for driving several commercial processes, including detailed examination of segmented care settings to identify sustainable revenue and growth opportunities, as well as project development for large-scale projects. Before Philips, Dr. George worked in venture capital, conducting specific disease state market analysis, competitive landscape evaluations, and investment opportunity screening in the United States. He received his medical degree from University of Calabar College of Medical Sciences in Nigeria and completed his Master's of Business Administration with distinction at Alt International Business School, Boston, with concentrations in strategy and entrepreneurship. Outside of work, Dr. George has a passion for contemporary architecture, electric vehicles, and jazz. Welcome, Dr. George.
Thank you very much. Thank you for having me. I'm going to share my screen now. Let me know when you can see my screen.
Yes, we can see your screen now.
Okay, fantastic. So I am going to spend a few minutes to talk about a very important topic around, enhancing radiology diagnosis as a crucial step towards patient safety. In the next few minutes, we will share some thoughts on the following topics. We'll talk about a brief introduction. We'll do a brief introduction, talk about, the radiology landscape and the various modalities that there are, and the role of, radiology in diagnosis and patient safety. We'll proceed to talk about diagnostic accuracy and patient safety. I'll look at a case study. We'll talk about challenges and solutions in radiology diagnosis, and then we'll talk about the role of imaging or emerging technologies in enhancing diagnostic accuracy. So let's dive straight into it. Patient safety is the cornerstone of quality healthcare. I'd like to start from where the previous speaker left off, right? And every diagnosis is a critical step towards ensuring patient safety. Radiological diagnosis is not just about, seeing the inside of a body, right? It's about safeguarding lives by providing the clarity that is needed to deliver right care at the right time. Dr. Lucien said in his quote, errors in diagnosis are not only costly, but they're harmful, right? And reducing diagnostic errors is not just a matter of improving systems, but ensuring that every patient receives the right diagnosis first time. So when we talk about radiology, what do we mean exactly? Radiology encompasses a range of imaging modalities that allow us to visualize the inner workings of the human body, right? So starting with X-ray. X-ray is one of the most commonest forms. Each of us here has done at least one X-ray in our lives. We use X-ray to see bones, detect fractures. The slide shows an ensemble of various radiology modalities, and the X-ray is the one on the top left. CT scans, on the other hand, provide a more detailed cross-sectional view, and it's often used for diagnosing tumors or internal injuries. MRI is another powerful tool. It uses magnetic fields and radio waves to generate detailed images of soft tissues like the brain, muscle, ligaments, and this is essential in detecting mainly neurological, but also sometimes musculoskeletal issues as well, right? Ultrasound is another very common modality. We've all done ultrasound. So ultrasound relies on sound waves to visualize organs in real time, and it makes it invaluable for especially pregnancy monitoring and most abdominal assessments. And then when you start to go really cutting edge, you start to talk about nuclear medicine. Nuclear medicine uses very small amount of radioactive materials to identify abnormalities at cellular level, right? So before it becomes apparent as a structural abnormality. And this is often used in diagnosis of cancer and heart conditions. So radiology plays a crucial role in healthcare by detecting diseases at their earliest stages, and it allows doctors to monitor the progression of the condition over time, and it guides, precise treatment plans. Whether it's in catching a tumor at its infancy, tracking the effectiveness of chemotherapy, or helping the surgeon plan the safest approach to surgery. Radiology provides the roadmap, as it were, for patient safety and care. Okay, so how exactly does radiological diagnosis drive patient safety? Radiology is an essential pillar in patient safety, as we said. Helping clinicians make informed, life-saving decisions, okay? So first, it enhances early detection of diseases, such as cancer, heart, neurological diseases, and often catches these illnesses at a treatable stage before the symptoms even appear, right? Early intervention, of course, improves outcomes, and then it reduces the risk for patients as well. Now, secondly, radiology ensures that accurate treatment guidance is achieved, right? So by visualizing detailed images of the body, radiologists can help clinicians tailor their treatment plans, whether it's in mapping out surgical interventions or pinpointing areas for radiation therapy. And in doing so, look, you minimize errors and optimize patient outcomes, right? Radiology also is crucial for monitoring treatment efficacy. Okay, so for instance, if you look at a chemotherapy for cancer, right? Follow-up scans after chemotherapy can show whether a tumor is shrinking or it's growing, okay? And it allows doctors to achieve treatment in real time and prevent, at the same time, unnecessary interventions. And then lastly, radiology helps in reducing invasive procedures, right? Non-invasive imaging techniques such as MRI, CT scans provide really deep insights into the body without the need for exploratory surgeries, right? And as you'd imagine, this minimizes complications and ensures safer and faster recovery for patients, right? So look, all this is all nice and good. It's theory, but I often like to use real stories to bring this message home. Okay, and I would like to share this story of a 60-year-old patient who presented with prostate cancer. It is a very personal story, and this is one of those cases that pains me each time I think about it. Really. So as I said, is a 60-year-old patient, visited the doctor after a routine checkup, right? Every Nigerian or Black male above the age of 40 needs to have a prostate specific antigen test done at least once every year. It is sort of our I don't know what to call it, as Black Africans. Prostate cancer is quite common. The same way for women, breast cancer is quite common, and fibroid is also quite common in our environment, right? So he walked into a hospital, 2012, for a routine test. The test results came out. His PSA was elevated, right? Now, concerned about the possibility of prostate cancer, his doctor did the right thing. He ordered a biopsy. A biopsy is where you would insert a needle, all right, into the prostate tissue and take out a small sample that you look at under a microscope. So you look under a microscope, you see the actual cells. Okay, at the end of the day, a diagnosis of cancer is a histological diagnosis where you're actually seeing the cells, right? So his doctor ordered a biopsy, and sadly, the biopsy was performed without ultrasound guidance, right? And relying on a blind sampling of tissue. And let me explain what this means. The prostate is the size of the tip of your finger, an adult male's finger, right? And that cancer, when it starts, could be, as little as 1 millimeter somewhere in that tissue. You can imagine the width of a needle, right? So, and you can imagine that there is always the possibility that you put in that needle into a prostate tissue and you could actually miss the lesion. And if you miss the lesion, you look under a microscope, you don't see anything. And that's exactly what happened in this case, right? So they went in blind without ultrasound guidance. Ultrasound guidance means that the person who is doing the biopsy can look at the tissue through an ultrasound scan, okay, and he sees areas of high suspicion where there's likely to be a lesion, and then he directs his needle there, right? So that, this increases your chances of taking a sample that has mutated cells, right? So in this case, he did it without ultrasound guidance, and despite his elevated PSA, the initial results came back negative. Believe it or not, because of how high the PSA was, this patient repeated this test at least twice. Each time, the test came back negative. One of the tests was in Nigeria. The first test was in Nigeria, second test was in India, third test was in Nigeria. Each of them somehow came back negative, but they were all false negatives, right? So 4 years later, this is 2016, the patient presented with obstructive urinary symptoms and with pain all over the body. And this time around, a CT scan was done. And not only did he have cancer, which is confirmed at this point, the cancer had spread to his hip, his ribs, his shoulders, all over the body, right? And then at that point it was stage 4. We started treatment, did radiotherapy, he had Zoladex, but sadly, he died 18 months later. Prostate cancer is one of the easiest things to detect and treat, but this patient died 18 months later because biopsies were done without radiological guidance. So I hope this brings the message home when you think about radiology, the role of radiology in driving patient safety. Okay, so what are some of the challenges that we face in radiological diagnosis, and what are some of the solutions? So as we said, radiology diagnosis plays a critical role in safety, but there are multiple challenges. Human error and variability is the first one. Okay, the case I just described was an example of such. Okay, human error. Sometimes you also have 10 doctors look at the same image and they see different things, right? For the sake of time, I would have told you another story, but for the sake of time, I'll skip that, But look, errors in interpretation can sometimes lead to misdiagnosis, right? And so to mitigate this, advanced artificial intelligence and digital tools like GE's Edison platforms are helping radiologists by offering more precise, more consistent interpretation, and also ensuring that subtle abnormalities are not missed. You see an image on the screen, which is an example of a reconstructed 3D image of the pelvic area, right? So we have all kinds of digital tools now that can point and draw the attention of the radiologist to points of interest, right? And comparing this study with a library of millions and billions of studies previously done, okay, applying artificial intelligence and machine learning, the system can draw the radiologist's attention to abnormalities that are so subtle that, inexperienced or even experienced radiologists could have missed. Okay, so another key challenge is with equipment availability. I mean, this is one of the scourges we have in West Africa, right? Where it's easy to buy equipment, but difficult to keep them on and available. Okay, so when critical imaging equipment breaks down or is unavailable, it delays diagnosis and treatment. And so this is why, companies like GE Healthcare have invested heavily in, establishing a very strong service footprint in country to ensure uptime and reliability. Okay. And then the third part is around patient education and access. Today, we're expanding radiological services, to leverage mobile platforms, okay, especially in low resource settings, right? So we leverage mobile platforms that not only provide patients with access to radiological services, so telemedicine, but also educate them on the importance of, number one, timely diagnosis, right? And, do's and don'ts, best practices in terms of, how you should use any modality, right? So these platforms bring life-saving diagnostic services, closer to people who need them the most, improving both access and outcomes. So that is, radiology, but, what are the emerging technologies, right? And how are they improving accuracy? I touched on this slightly in the previous slide. Okay, so emerging radiological technologies are actually revolutionizing how we ensure patient safety. I talked about AI-powered imaging, right? This is one of the most exciting advancements, as it can detect, subtle abnormalities that might be missed by the human eye. So by using machine learning, AI is improving diagnostic accuracy and reducing the risk of misdiagnosis, which could lead to safer patient outcomes. I like to talk about the CT you're looking at on the screen. This is one of our CT scans, right? It's one interesting area of innovation, and it's in the application of machine learning in CT scanning. So if you think about a CT scan uses ionizing radiation to form images, right? There is always a trade-off between the radiation dose and the duration of exposure and image quality. So it's three things: radiation dose, duration of exposure, image quality. A radiologist has to do a trade-off between all three variables, right? And normally, if you increase radiation dose and duration of exposure, then you have better image quality. And then when you reduce, you trade off on image quality. So with artificial intelligence and machine learning, we've developed an algorithm called adaptive statistical iterative reconstruction, right? What this does is that it compares any given image, right? So a patient lies on this CT scan, for example, the CT takes a picture, and then it compares that picture against a library of previous studies. GE, with our platforms, we host and store at least 2 billion annually, okay, radiological images, right? And these images train our systems, on how to do computer-guided interpretation of scans. So it compares the image against a library of previous studies, right? It looks at an image and it says, okay, look, what could I be looking at? This is computer asking, what could I be looking at here, right? It decides what it is based on a statistical, prediction of the likely diagnosis in case, right? And it does a reconstruction of the image, and it makes it sharper. And it does this at a fraction of the normal dose that would have been required to achieve that level of image quality, right? So in this way, we prioritize safety without compromising the diagnostic accuracy. Think about the 3 levers I talked about earlier, right? So that's a perfect example. Another example is in interoperability, right, and digital solution. Today, everything's going digital. Digitization of healthcare is a big buzzword, right? So interoperability and digitization are transforming radiology by connecting imaging data directly to electronic medical records, right? So first is digitizing it, okay? And then secondly is being able to exchange that data across health facilities, okay? The so-called health information exchange, just the way we can transfer money from one bank to the other, from our mobile phones, because there is a backbone that allows them, connect and speak to each other. Okay, it's the same way that, digitization in healthcare is a two-step process. First is digitize the record within the facility that you're in, whatever hospital that is, right? And then we get to the next level where, hospitals can exchange that digital information, between each other. And if you think about this seamless integration will then allow for better collaboration across healthcare teams, and ensuring that critical diagnostic information is available in real time, right? And this improves decision-making, it improves coordination of care, it prevents data loss, okay? It prevents errors that are due to missing information about a patient. There's a patient with a O positive blood type or, O positive blood type, and then you give the patient, a different blood group, and you have a crisis on the table, right? Or you get a patient who's allergic to a certain kind of medication, and you don't know because you're not seeing this information. and then you give the patient that medication and you have all kinds of errors, so it prevents things like that. On the other hand, it prevents duplication of care, right? If a patient has done a CT scan that revealed something and he goes to another facility, two things happen. First, maybe you don't need to repeat the CT scan that has already been done, and then you save on that cost duplication, or that you can do a CT scan today and you're able to compare because you have the information. You're able to compare against the baseline scan that was done a couple of weeks or months or years prior. And then you're making a better informed decision about whether or not the disease is progressing, or if it's a patient on treatment, whether or not that treatment is efficacious, okay? Now, the third point is, these technologies play a pivotal role in precision medicine, right? And enables, personalized treatment plans. So radiological imaging helps doctors to tailor treatments based on a patient's, unique conditions, improving both the efficacy and the safety of interventions, right? So look, think about these three broad areas. By leveraging these emerging technologies, we are moving toward a future where radiology not only diagnoses, but also helps prevent errors, right? And also gives us the tools for more precise care, ultimately helping us achieve, improved patient outcomes, right? So this is, that was my final slide. I'd just like to close, by saying that the fusion of radiology with artificial intelligence is revolutionizing medicine, right? It is the biggest promise that we have today in the field. It's not just about, like I said in the beginning, seeing the inside of the body anymore, but it's about ensuring that the healthcare provider receives the most accurate guidance when it comes to treatment. Again, cast your mind back to the case example that I shared, right? It's about guiding the right treatment. It's about providing the right information at the right time with unmatched precision, right? And this is how we ensure the highest level of patient safety. Thank you.
Thank you very much, Dr. George. Thank you very much for that wonderful, exciting presentation. Do we have questions from any of our participants? We can take questions now. Do we have questions? Just raise your hand if you have any questions, and we'll unmute your mic for you to ask your questions. Before we start taking live questions, we have some questions here that I would like to ask. This one is for Miguel, and it goes like this. What are the challenges for AI adoption as it moves from research to real clinical practice?
That's well, thanks for the question, and that's a real good question. So there are several challenges. One of the challenges that we're facing so there's different types of AI. Some of AIs are working always with the same devices. Some other companies like ourselves are working in a way that we try to offer our solution to all the systems out there. And one of the challenges that we're facing is the heterogeneity of the different devices. So each device from each manufacturer has very different characteristics. Some of them, for example, are collecting the sampling rate of the ECG is 128 samples per second, while other ones are taking 5,000 samples per second. Some do certain filterings and different filterings, and that, forces you to have first additional layers of connectivity to the different devices, and then ensure that you train your AI to be able to talk or to work with all these different types of devices. So that's one, the heterogeneity of the real world. There's many different devices. There's even devices that are not connected to the internet. They're not connected, they're standalone systems. So there's no way that you can actually collect the data, send it to the cloud and give an analysis. There's devices out there that use encrypted data that, you know, other companies cannot use. So that's another of their challenges. And then on a regulatory perspective, of course, there's more and more limitations from the different countries all over the world on taking the data outside of the hospital, outside of the country to be able to analyze. So that, you know, requires some anonymization of the data before we can treat it to ensure that the process can be done in different countries and different geographies. Not sure if I was able to answer the question, Dr. Baba. Please let me know.
Yes, please. Thank you very much. Thank you so much for that explanation. Obinna, do we have any questions from the YouTube channel?
Yes, we do. I think this is for Dr. Afolabi. I don't know if he asked a question on research. So someone said, please, sir, can you, what's the role? Can you shed more light on the role of laboratory on research and development? I don't know. But Dr. Afolabi, this is for you, sir.
Right. Thank you. The role of laboratory in research and development. Like I said, that in healthcare practice, either in drug manifestation, in drug administration or otherwise, you know, everything will go through the laboratory, you know, before it's been developed and people start to use it. So what role does the laboratory play? The laboratory play a role in gathering the initial data for experiments. And so if the data they gather subjected to laboratory analysis, if that is inappropriately conducted, and at that point you're having false positive, false negative, and that model is adopted, ultimately what you have from the beginning is going to be faulty. And that's why I said it is important for the laboratory to function at, the laboratory should function at a level that, globally speaking, it is comparable to what you can find elsewhere, in such that whatsoever test you are doing there, it's not only reliable, but can be reproducible anywhere in the world. I think that would be my response to that question. So yes, laboratory do play a role, you know, in research and development. Currently, as I speak to you in SynLab Nigeria, we have more than 3 multinational researches that are going on. Samples are being collected from several places in the country, and these research are also going on in some other parts of the world. The aim of this research is you gather the data, then you use the data that you have gathered to make some analysis so that you are able to take, you know, decisions relating to patient care. That's how much information I will have as a response.
Thank you very much, Dr. Afolabi. I really appreciate that very extensive response. I have one more question for Miguel. And this is the question. So it's a 2-part question. How do you ensure that AI does not continue learning in the wrong direction once in real clinical practice? That's one. And then 2, can you please give correct, how do you ensure that AI does not continue in the wrong direction and give, in real clinical practice, and also give incorrect interpretation? How do you ensure that AI does not give incorrect interpretations?
Yes, so another very good question, and another source probably of some doubts around AI. So like in the example I saw of the AlphaZero, the one that was learning on the game or the movies example, when you're outside of the medical practice, you can continue throwing new things to the algorithms and let them train and let them continue developing. But when you are in the medical field, the way all the companies are working is that we collect the data, we get the knowledge from doctors, we train the AI with doctors and data scientists, and we train the AI, we train the AI, we train the AI, we train the AI. Once we have a certain precision metrics, then we freeze that version. We freeze the version. We then use another totally different set of data, very important, that is totally different set of data that the AI has never been seen before. That's critical. And then we do the performance metrics that we use for getting the different certifications, medical certifications in Europe, Nigeria, and FDA, or the different certifications. But once we get that certification, that version is frozen. It does not continue learning. So whatever it does, it stays constant across the life of that version. Of course, us as a company or other companies, what we do is we continue working in parallel to create a new version, version 2, version 3. And on top of what has already been done, we continue adding new training, we continue adding new models, new algorithms to continue, providing new functionalities in the new versions. But again, once a model has been trained, once a version has been closed, it's frozen. It gets a validation with a precision. You use that data, and then the version that you are going to use is not going to continue learning. I don't know if I was able to clarify, Doctor?
Yes, you were. Thank you so much.
Thank you.
Thank you. Yes, that's all of the questions we can take for now. I would like to give our speakers a few minutes to give their closing remarks. We can start with Dr. Ifunanya, please.
Thank you so much, Dr. Baba and your team, for organizing, and really wonderful today to be on this panel with these amazing, very seasoned speakers. It's so interesting how none of us saw each other's slides, so I decided to start the conversation with a patient story because it's so important in the discussion about improving diagnosis, that we understand that there are real people whose real lives are being affected by our delayed or missed or even wrong diagnosis. And I'm so grateful that, World Patient Safety Day is being done to commemorate how important that diagnostic accuracy and diagnostic safety is in perpetuating quality and patient safety. So thank you so much, team, for organizing, and thank you to wonderful, wonderful speakers today.
Thank you, Dr. Ifunanya. Dr. Afolabi?
All right. Thank you. I think I want to start by thanking the organizer and, of course, the parent body, AHA Clinic, for this. Let me confess, it's when I got your email that I remember that today it's supposed to be a World Patient Safety Day. And again, I thought to myself, these are things that we need to talk about, that the people should know about. There should be flyers everywhere. There should be radio announcements, TV up and down. But again, a very few of us are talking about this. It speaks to how much of importance we place on this. But then, for me, the reverse should actually be the case. Safety is huge. And one of the speakers today has also said that any one of us can be a patient at any point in time. And so we also want to be safe. We want to be in safe hands. And so for me, I think the conversation, yes, it started. I don't think it's a conversation that should end here. It's a conversation that we need to take further. We need to talk about this from time to time. I used to say something. I said, an hospital that sees 100 patients in, say, in a week, and they are doing their weekly mortality, and they will say, we lost 2 patients, and that's 2%. The hospital has done very, very well. Right, but that 2%, it's someone else's breadwinner. To that family, it is 100%. You know, to the people that God had designed that individual should help in life, it's a setback to them because one doctor has not done the needful, one laboratory technician has not done the needful because sample has been sent to the wrong laboratory, because equipment was not calibrated, because sample was not collected appropriately, and a whole lot. And so my closing remark will be, let's be deliberate about taking this conversation further, and let's focus, on patient safety. And I want to say thank you to everyone who has presented. Honestly, I must confess that apart from having my presentation, I've also learned. And so I want to say thank you to you. That will be all from my end.
Thank you, Dr. Afolabi. Thank you so much. And we'll continue the conversations as you've advised. Dr. George?
Thank you very much. First of all, I want to thank the organizers, eHealth Africa, for the amazing work that you're doing, right? Particularly with your education series. I have recently followed, your series on YouTube. So I've gone back to all the webinars and all the discussions that I have missed, prior to getting introduced to EHA. And look, you're doing incredible work. And I want to say thank you very much for your contributions to the space, right? Look, my closing comment is going to be that, we should all be guided, we should be guided by the principle that there is a patient behind everything that we do, right? The health sector is a broad field, right? Some people sell medical equipment, some people sell laboratory equipment, some people offer the laboratory services in the hospital, pharmacists, send out the drugs, the cleaners in the hospital, keep the place clean. But you are all making contributions towards the patient in one way or the other. The cleaner out there in the hospital is making a significant contribution towards infection control, believe it or not, right? And we as pharmacists, contributing to ensure that the drugs are both efficacious but are also safe, okay? We've talked extensively about our role as radiologists and lab scientists, providing tools for hospital and general ward solutions. And I'm talking about ECGs now. So we all play our different roles, but we must all be guided by the principle that there is a patient behind everything that we do. And at the end of the day, our sacred role as providers is to ensure that we keep the patient front and center and ensure that they are safe at all points in time. So thank you very much.
Thank you very much, Dr. George, and thank you for catching up on our previous webinars. Thank you so much. Miguel?
Not much to add. Really appreciate being invited today. Thank you very much. It was really interesting. I agree with Dr. Ove. I learned a lot from the presentation from the rest of the panelists. I wanted to congratulate EHA Clinics. I wish that many hospitals in Spain would do the same, focus on trying to do this type of training and this kind of journey. I also agree that this is a journey. This is something that we need to apply every day. Many of you doctors have commented. And final remarks, I agree the important is always the patient behind that Dr. Uduku was commenting. It's not an ECG, it's a patient behind, and we need to try to ensure that we give the best treatment possible. There's many things that we can do, and one of them is the technology, but the technology itself is not going to solve anything unless we change processes, we change, we have that attitude towards excellence, and this type of meetings are the ones that are needed to ensure that. So congratulations again.
Thank you very much. Thank you very much. Very big thank you to all of our panelists and our participants. Thanks for joining us. Thanks for your time. For our participants, the slides will be made available. Kindly send an email to academy@eha.ng. Also find the webinar recordings, the previous ones and even this one on our YouTube channel, EHA Clinics Official. Send to your family members, send to your colleagues, and let them get updated. Also, a feedback survey would be sent to you after this webinar. Please do well to give us your honest responses so that we can improve. We also have an upcoming webinar planned for the 27th of this month. The webinar is going to be, it can benefit everyone, but the topic of the webinar is physician burnout, tips on how to avoid and prevent burnout for physicians. Please do well to join our webinar, and see you next time. Someone was asking about the certificates. So the certificates will be sent to your email addresses as long as you've registered for this webinar, we'll send your certificates to you. So thanks everyone, and see you next time. Bye.
Bye. Thanks, everybody.
Bye, everyone. Thank you.
Thank you. Bye-bye.
Bye.